So I am coming to you today from Cambridge, Massachusetts at Harvard University, and we are very delighted to have Nick Klasinga from the OECD, and he is in Paris, France. And Nick, thank you so much for joining us today.
It's a pleasure.
So Nick, I was hoping, could we start off by just giving everybody a sense of what is the OECD, what does it do?
OECD stands for the Organization for Economic Cooperation and Development. And it's basically a club of countries, industrialized countries, that try to exchange information about economy and economics. Over the years, and especially since the 70s of the past century, the OECD realized that healthcare and developments in healthcare are an important part of the national economies. So that's how a medical doctor like me can end up in an organization which is mainly populated with economists.
Can you give a little background about how you came to work in the OECD, what your portfolio of activities look like right now at the OECD?
Yes, I have a training as a medical doctor, but actually I'm more a health services researcher. So I've been involved in studying the measurement of quality and the improvement of quality over the past 30 years. But in the past 8 years, I had the pleasure of coordinating the healthcare quality indicator work here at the OECD. And that is on the one hand trying to collect international comparative data on the quality of care, but we doing more and more work which is more analytical, trying to understand differences between countries. And one piece of work we've been involved in the past 2 years is that we also do in-depth country studies where we try to find out how to link the performance indicators and the information of quality of care with the actual policies that are in place. So it's a mixture of international comparative statistics, indicators, and policy analysis to help understand what policies result in better healthcare outcomes.
Let's take a little tour through history, if you don't mind. Let's go back to the starting of the HCQI, the Healthcare Quality Indicators Working Group. What motivated that? Why did the OECD get involved in creating quality indicators and creating comparable measures?
Well, to really go back in time, we have to go back to the 70s in the past century. That was the moment that the OECD started looking into healthcare. But the thing they were collecting were mainly data on healthcare costs. So I think the start of the healthcare quality indicator work can be pinpointed in 2002. In that year, there was a ministerial conference. Every 4 years, the ministers of health of the OECD countries, and at the moment we have about 40 countries who are members, they meet up and they discuss urgent issues. And one of the main issues that was discussed at this meeting in Ottawa, which was focusing on healthcare outcomes, was that the ministers concluded it's not enough to have just data about that healthcare is getting more expensive and getting information that people live longer. We actually want to learn how good our healthcare systems are doing. So we need far more data on the performance of our healthcare services. We want data on quality of care.
So the point is they want the information on spending, they want the information on patient outcomes and sort of public health, but they need the information in between about what role the health system is playing, how well the health system is performing, so we can really make the link between spending and population health, right? Because that seems to me like to be a critical middle part.
That's correct, and also in the conceptual framework that the OECD is using for quality of care, we make this sharp distinction in trying to measure what is the relative contribution of the healthcare services and trying to distinguish that from all the other factors like environment and behavior and genetic backgrounds that determine health. So we really try to establish what is the relative contribution of the functioning of the healthcare system as the collective of healthcare services to the health of the population.
Quality obviously comes in many facets, from patient experience to safety to effectiveness. Can you talk about in broad terms, where has the HCQI gone? What are the areas that it has focused on in terms of developing indicators?
If we look historically, the first thing we try to do is to take stock of the existing indicators in the period 2002-2005. So by then there had already been some international comparative efforts, and basically the areas we were looking at were primary care, hospital care, mental health care, infectious diseases. Those are the first areas where we really explored in the literature. But when you really try to see what is the evidence on the validity and reliability of this indicator, and you then ask the question, is this fit for international comparison? Could we get data in a comparable way? Then the number of indicators you can work with is far more constricted. The initial group of indicators we work with were on acute care and cancer care. For acute care, we looked at the 30-day case fatality rate for acute myocardial infarction and stroke. So basically you ask from the people who are admitted to a hospital with a diagnosis myocardial infarction and stroke, how many are still alive after 30 days? And you base that on the administrative databases that are available. For cancer, we have very much been promoting to look at 5-year survival rates. So we look at what is the 5-year survival rate for breast cancer, cervical cancer, colon cancer, and of course you try to present that together with the mortality data. And mortality of a cancer together with 5-year survival gives you a rough idea how good the health services are performing in tackling that, especially if you can add the screening rates.
Can you talk a little bit about how that has evolved? What are the indicators that HCQI is looking at now? Where else has the healthcare quality indicators group gone?
We try to do more work on primary care, and one of the hurdles there, of course, is the limitation of good data systems that capture what's going on in primary care.
Yep.
So as a proxy, we use the administrative databases from the hospitals to look at admission rate for chronic diseases. For example, we look how good is the system in avoiding that people with COPD, asthma, diabetes, chronic heart failure end up in a hospital. So we look at potential avoidable hospital admissions for chronic diseases. But another area we've been working in the past years is to look at prescription data. So we're now exploring work where we look at prescription indicators, and well, one of the classical ones is to look at antibiotic prescribing and look at the third and fourth generation antibiotics as a percentage of the whole. And by themselves, these statistics are, when you look at differences between countries, are very revealing, because they see that you have huge differences between countries.
Got it. So it sounds like you're looking at what in the US we talk about as ambulatory care sensitive conditions, or also known as prevention quality indicators. And the notion behind that, as I understand it, Nick, is that if you have a really effective primary care system, if you do a really good job of managing people in the outpatient setting, you should have very, very few of those hospitalizations for congestive heart failure, for diabetes, for asthma, because they're really chronic diseases that should be managed optimally in the outpatient setting. And so it's a measure of the system not performing as well as it could if you have high admission rates for those conditions. Do I have that right?
And that's exactly right. So it's basically trying to see, is the primary care system able to deal with chronic diseases? And yes, potentially avoidable hospital admissions are a way of looking at that. Also looking at the compliance with medication for chronic conditions is another way of looking at it. Because we also find that compliance is very much related with the strength of the primary care system.
I'd love to hear from you what HCQI is doing on patient safety. I'd love to hear what you guys are doing around patient experience, and any other kind of international benchmarking efforts that you think are either starting or are going to be coming down the road over the next couple of years. So patient safety, patient experience, and anything else.
In the beginning, everybody said it's impossible to compare countries on patient safety. Nevertheless, we took the patient safety indicators that are used in the US, and we first explored, are the data systems in other OECD countries good enough to calculate these same indicators? The first pilot run showed us the answer is yes. In principle, this can be done. But one of the lessons we learned is that we have to adjust for the quality of the database. If you want to compare patient safety indicators based on administrative databases, your indicator is very sensitive for the number of secondary diagnoses. That basically means how detailed do you have information in your database on patients. That partly has been solved, so we now have a method of collecting those data, adjusting for the level of detail of the database. And over the years, we get more and more information on making these patient safety indicators really comparable. So we now have a core set partly related to surgery, partly related to obstetrics. The second group you asked about was the patient experiences. What we did was basically to try to standardize a core set of questions, which we managed to do, which are now embedded in the regular patient surveys in many countries. We found out that there are a lot of cultural biases. You really have to do a lot of cognitive testing to see whether the understanding of things are the same in different languages. But we have some basic information on that. I think what we've done more recently is work on mental health care. For a long time, we focused on readmission rates for schizophrenia and bipolar disorder. Last year, we decided that it's not really actionable, that it's very difficult to interpret. So the indicators we're now working on have to do with excess mortality. Excess mortality means that you look at the life expectancy of people who have once been diagnosed with schizophrenia or bipolar disorder. And in most OECD countries that can measure that, we see that that's much lower than the average life expectancy. So if you have a country with a life expectancy of 79, then it's not uncommon that the person who has once been diagnosed with bipolar disorder has an average life expectancy of 55. One of the key things of calculating these things is that you need to make a linkage between your administrative databases and your mortality statistics. So these kind of indicators can only be generated if, on the one hand, I can use a database that has the diagnosis with another database that contains whether a person is dead. And at this moment, there's only a limited number of countries that can do it, but the number is growing. So, like with other indicators, I'm pretty confident that over the coming years we will have better indicators on mental health care also to have a more complete suite of indicators on quality of care.
The work you're doing trying to link these databases strikes me as, sort of a good example of how challenging it is to do this at the national level. You've got to start linking data together. You've got to start looking at this in a comprehensive way. Of course, the challenge will be, even if we could measure it, then how do we turn around and start using that information to improve care for people with mental health disorders? Anything else on mental health that you want to mention before we talk about any other sort of activities?
Well, I can only mention that there's a continuous debate about how to use suicide rates. And that also goes into time. I've been in expert groups that wanted to measure suicide rates as an indicator for mental health care, and then 1 year later the same group would say, no, that's not fair to assess the mental health care system by looking at the suicide rates. We're now doing a new attempt under the leadership of Denmark, where we try to reassess the suicide rates, but then especially look at suicide rates of people who are admitted to a mental health care facility, or suicide rates of people who have been in contact in the past 30 days with a mental health care service. And so we try to get there, but as I said, it's more it's a fluctuating thing, and nobody is really happy with that. But you're totally right, Ashish. There are very little really good, strong mental health care indicators that tell you about the quality of mental health care.
Where do you think the HCQI work is going? What are some broad areas of activities that you would like to see happen over the next few years?
Where we are going is very much dependent on the quality of the information infrastructure in the member states. It has to do with the capability of a country to link different databases and or to maximize the use of data they capture in electronic health records. Last year, the OECD released a report on how to strengthen your information infrastructure to measure quality, also to support countries in doing that, because that will determine to what extent we will be able to come up with good comparative measures. That being said, I'm also thinking that in addition we will see more analytical work. Last year we released a report on cancer care. So we basically demonstrated that the differences in performance on cancer care between countries are partly due to the amount of money they have. Rich countries have better results, but an important part of the variance between countries is determined by how good you have organized your cancer governance. So do you have national guidelines? Do you have feedback on performance? Do you have national screening programs? Do you have a national debate on concentrating cancer services, that hospitals should do a minimal amount of operations only? So we see that we can find an association between these kind of policies, having an active cancer governance policy in place, is associated with better performance. What we now try to do is to replicate that study, but in the area of cardiovascular disease. And that, although the report is not out yet, we see a similar pattern, because we have lots of data on cardiovascular disease, diabetes, and stroke, but we can see that in all countries it's getting better. But in some countries it's going down much quicker than in others. And that's not just related to the amount of money you pour into it. That's also related to whether you have a whole system approach to organizing cardiovascular care. For example, for the acute phase, it means it's not just good enough to have excellent facilities in your hospitals with PCIs and CABG and a stroke unit. No, it's linked to what people can do as self-recognition of the complaints, how in the public domain you can have organized resuscitation, how good your ambulance services are, how you staff them. So it's basically the whole pathway of care that you have to organize. And some countries try to do that deliberately. There are government attempts to really try to structure the whole pathway. In other countries, it's left to the various services to do it in their own way. And we hope that we can demonstrate that those countries that really make an effort to have a whole system approach and to moderate the pathway, just like with cancer, are getting better results than the countries that just leave it to the various individual healthcare providers.
Got it. So I'm going to summarize, and I hope I don't take it beyond the data that you're describing. When you look across countries and you look at performance, you look at improvements in performance over time, countries that have really focused and taken a systems approach to care, from the onset of symptoms through the patient arriving at the hospital to the treatments in the hospital, on average tend to do better, tend to see bigger gains in outcomes than countries that are not taking such an approach. Is that a fair summary of where you think the data are?
I think that's a fair summary. And again, this is all associative data, sure. But especially when you collect trend data over 20 years, when you try to link the trend data to the health system characteristics, and when you link it to the policy interventions, it becomes a quite convincing story. That's why both in the cancer report and in the report on cardiovascular care, this is the message we try to send to the countries, that these improvements in quality of care don't come by themselves. It has to do with how you organize your system, and it has to do how the individual components in the system are actually linked.
So Nick, one of the things that comes up often in discussions around health systems is people say, well, we don't really have good measures for quality. I want you to actually take a step back and, not speaking on behalf of the OECD, but your expertise, your personal opinion, do you think we are at a point today where we have reasonably good ways of measuring healthcare quality?
If you want to measure it, I think we did all the thinking about how we can measure it. But if you have the right data systems, I mean broad enough data systems to do the risk assessment, it's possible to measure it. And especially the closer you are to your real work and to the unit where you collect the data, of course, the better you can do it.
For you, your job in the HCQI work is to think about measures that are comparable around 30, 40 countries. For students in the course or for other people, they're going to be thinking about, can I measure the quality of the hospital where I work or the hospital down the street? When you're at that much more of a closer granular level, it feels to me like what I hear from you is the validity of what you can do is even potentially better.
Yes, that's exactly the point I want to make. I think everybody, when you're a medical professional and you're doing your work, you can document it in such a way that you can assess what the outcomes of your work are and whether you are doing the things that you were supposed to do. So process measures and outcome measures in your own work can be collected, and the closer you are there, the better the learning, because you can put the data in context, you know what the story is about the patients, and all what comes after that is looking at the group, looking at the hospital, looking at the region, looking at the country, looking at the world, is just adding up and making it more complex methodological to have risk adjustments. But the closer you are to the context, the better you are capable of understanding the data. And I think in essence then it comes far more to the willingness to actually learn from your own data than from the fact that it is measurable. Yes, it is measurable, and yes, if you know good enough your own situation, you know how to value those measures and not make them in something absolute, which is, of course, as you well know, one of the dangers of measuring quality of care, because if there's no reflection by the individual professional and on the level of the department or the hospital, you really run the danger that somebody who doesn't know the context and only gets the data in the capital of a country looking at data and comparing hospitals, that person makes the wrong inference. Partly because the risk adjustment is not sufficient, partly because the story behind it is not known. I am very much in favor of keeping data and context as much as possible together when you make your inference.
So OECD made up primarily of high-income countries, some middle-income countries, but countries that have more advanced health systems have a lot more data, a lot more administrative data. You've started doing more and more work, as I have understood it, on sort of low and middle-income countries and how they might think about quality. Can you talk us through what your thinking is about those countries, the work that OECD has done in that area?
To start, yes, the OECD has mainly members who are the industrialized countries, but a growing number of countries and new member states are transition countries. So when you look at Mexico and Chile, then you see that also in the quality indicators, there's a huge gap between what we measure in terms of 30-day case fatality rate in those countries and what we measure in countries like Sweden and Norway and Malaysia as an example of a non-OECD country that really has been looking systematically at quality of care already for a long period. And I know they are continuously reconsidering how to do this. And that links very nicely to the point I tried to make earlier about strengthening the information infrastructure. It starts with the national governments. There is also an active collaboration together with WHO. One of the things we try to do there is to come with a story of how to build your national information infrastructure. You're right, many of these countries don't have the data, but that's also a challenge. They start developing it. If you move towards universal health coverage, if you start setting up a social insurance system, or you broaden your social insurance system like it's now happening in Mexico, that means that the wealth of data in your administrative data systems will increase. Are you thinking at that moment already of not just using those data for payments, but are you also looking at the potential use of those data for generating quality indicators? Another example is to discuss with countries on setting up cancer registries. There was a consultation of OECD and the World Bank with Brazil last year, and the main focus was to how to set up a basic cancer registry in Brazil. And actually that's a pattern I see in many countries, also in Asia. We had a meeting with, I think now 25 Asian countries last November on quality of care. One of the pieces of information we try to obtain is how are you developing your information infrastructure? Are you working towards cancer registries? How complete are your mortality statistics? Can you use your administrative databases for these kind of purposes? This is not an answer for your students, but this is an answer for the governments of these countries, that if you go to a new phase of development with universal health coverage, different mobility patterns that need to be dealt with, you can think about how you can strengthen your information infrastructure to capture the data. Then back to your students. Yes, of course, you can start with just collecting the data you have in your own situation by trying to see what is collected now, and is there any sort of systematic effort of monitoring data. And what I experience in many, especially the developing country, is that usually the data systems are built, well, as a thing that remains of support programs in the past. So many of them are still very much focused on one area, for example, a good database on malaria or on tuberculosis. And then of course the challenge is to broaden that, not just to have disease-based databases, but start thinking, okay, we're now going to broaden our database for our hospital system, or we're going to start up the data system for primary care. How can we link that to the data we have already available, and how can we build a data system that is helpful? So for the students, I really hope that they start looking around them and seeing what data are now captured and what efforts are there to systematically evaluate what we are doing. Not just the day-to-day, I saw these patients, I gave this and this drug, but can you really, over time, accumulate, get an overview, see complication rates, see results, and can you relate that to the way how the information infrastructure in the country is developing?
So I'm going to summarize 2 or 3 key points. For developing and transitional countries, quality remains, I think, a very important issue to focus on. They may not have had traditionally the same level of data infrastructure, but as more countries move towards universal coverage and as more countries develop social insurance schemes, that actually becomes the underpinning for potentially having data for quality. But as you said, Nick, if you think of it as only data for payment, that may not get you where you want to go. If you can, as you're building these schemes, think about quality, think about how these data could be used for quality, that has some potential great payoffs down the road. And then you mentioned a couple of very specific types of activities, cancer registries, you can imagine cardiovascular disease registries, registries that focus on major types of conditions. And that's the kind of thing that lots of countries are beginning to focus on and work on as a way to monitor quality and outcomes for these high-profile conditions. One last question on this part. You know, there are people who have made the argument that quality is really a luxury for high-income countries, that for low and middle-income countries or developing transitional countries, the focus really only has to be on access. Do you agree with that? Do you see the world that way? How do you think about that very big and important question, Nick?
No, well, I couldn't disagree more. I think quality is even more necessary in developing countries. If you have so limited resources, and if you put so much political engineering in generating a limited amount of resources to assure access, then you have the moral obligation to make sure that the services that people get are actually useful and are working, and is as important in a developing country as elsewhere. So yes, I heard the argument. Some people still think quality that is additional services or having a glass of water given to you during a consultation. No, that's not it. It comes down to really making sure that when services are delivered, they are the right services and they are delivered in the right format at the right moment. And that comes very much back to what medicine is all about. Medicine is assumed to deliver those things that actually work. We have the term evidence-based medicine. So if we try to make sure that we can deliver the things we are saying that we are delivering, and if we can really demonstrate through data that we're doing good, I think that's an essential part of every system that is dealing with universal access.
So you just heard from two terrific speakers, discussions with Nick Klasinga from the OECD and Jishnu Das from the World Bank. So let me give you my summary of how I have understood and really incorporated what they have talked about into our learning for the week. So Jishnu talked about some of the frontier work that he has done in assessing quality in India, in Paraguay, in other low-income countries. And the couple of key highlights from his work. One is in India, when you take a very basic case of a patient with a heart attack, and you ask, how often do people get the diagnosis and treatment right and not add anything else to that mix? The answer is 5%. About 5% of the times when a patient walked into a doctor's office having chest pain for a heart attack, the physician figured it out and gave them the right treatment and only the right treatment and nothing but the right treatment. This suggests that we have a staggering problem with effectiveness. But that doesn't tell us how we might want to measure quality on an ongoing basis. And when I pushed Jishnu and I said, what can we do to really monitor quality? He came up with three things, and I love them. One was measure effort. How much time does a doctor actually spend with you? The average physician in the public sector might be spending 60 or 90 seconds with a patient, not nearly enough to make a diagnosis or offer the right treatment. The second is how many history questions does a physician elicit? On average, he found in India that the answer was one. They asked one question and they were off to the races. And then the last was how many physical exam findings did they elicit? All of this is really getting at one notion, which is in low-income countries, quality measurement is as much about measuring effort and knowledge as it is about anything else. And that's where the frontier is right now, and that's what we need to push on, and that's where we need to move forward. Next, Nick Klasinga talks about the OECD and reminds us why it is that the OECD even got into the business of measuring quality. Because countries around the world were paying a lot of attention to how much money they spend on healthcare, but much less attention on what they're getting for it. And so quality measurement has really become part of the global agenda, I think, throughout the world. Then Nick dives in to what the OECD has been doing. And the way to think about it is a big chunk of their initial focus was on effectiveness, and it used primarily claims data, data that comes out of billing records from insurance. Since much of the healthcare that's delivered in high-income countries is through some sort of an insurance scheme, that's a pretty reasonable way to do it. What the OECD has done is move towards safety measures and patient experience measures. And so now we can begin to see that there are metrics that are happening in those domains of quality as well. And that, I think, is a very important set of progress moving forward. We asked Nick to speculate on what would happen for low and middle income countries, and he had a couple of really important insights. One is a lot of countries, not just the high income countries, but the low and middle income countries are developing registries around diseases, heart disease and cancer. We can grab metrics from those registries much more easily. The second is that the push towards universal coverage is creating new data opportunities. Lots of countries are now creating insurance schemes. Those give us data on what kind of services people are getting, and that, if we are smart about it, will help us design quality measures up front. Finally, a key piece of insight from Nick's talk was around ICTs, information and communication technologies. Now, we just touched on this. We have an entire session devoted to this with Professor Julia Adler-Milstein, who's really an expert on this topic. But the key insight from Nick that you'll hear reiterated again in a couple of weeks is that ICTs, IT, electronic health records, personal health records, other types of electronic systems can become the basis for so much quality measurement. We haven't figured out how to do this yet, but it's coming, and it's coming fast. And you're going to see more on this in the next couple of years.